Peter, ¿son las 5 ya? Shall we? Ready? Okay. Okay, 5 o'clock, German time. So, good afternoon. Thank you very much for coming. It's a real pleasure to have you here for this hearing symposium. Who doesn't know what hearing is? You all know what hearing is, okay. Then I will not say much about the hearing. We don't have much time for this roundtable. We have only 45 minutes. But I just wanted to remind you that hearing is a global network of centers of excellence in hearing rehabilitation. We go from adhesive devices to ABIs. We cover everything. And we cover also the 5 continents. We don't have much presence in Africa, but we are trying to improve that. But we have America, Asia, Australia, and Europe. And we're growing, and we keep growing as time goes by. We meet once a year, and this was last meeting, 2024 in Dubai. And every year we have 1.5 days of full dedication to hearing devices, and we really appreciate that. What we're going to do today is just make a spontaneous roundtable. We're going to have 3 couples and 3 topics. And they will come here, and we're going to talk like if we're on a bar. It's a social conversation, no slides, just a slide to let you know what the topic is. And we are going to share the time between these three couples and these 3 topics. So to start, we will have Professor Artur Lorens and Professor Kristen Rak. For those of you who don't know them, I'm sure most of you know them, Artur is a professor and head of the Department of Auditory Implant and Perception of the World Hearing Center at the Institute of Physiology and Pathology of Hearing in Warsaw. He has received the first award from the Minister of Health and Social Welfare for outstanding achievements in healthcare. And the hearing group is really honored to have Professor Lorens as one of our members and one of today's speakers. And the surgeon of this team is Professor Kristen Rak from Würzburg. He's the head physician and ENT specialist in the field of cochlear implants and middle ear implants at the University Clinic of Würzburg. Hearing is very lucky to have you, Kristen, as one of our most active members. And with them, we're going to discuss about single-sided deafness in children treated with cochlear implants. I didn't say that before, but I would love to have questions from you. So any wanting to ask something or make a comment, just raise your hand. You will get a microphone, and you can ask them. And for those staying on the back, you can also ask anything you want to the first couple. So let's get into the topic. Artur, how important is etiology in single-sided deafness in children?
Very important.
Okay, thank you.
I think that definitely the etiology gives us some predictive cues and predictors for the outcome. First of all, something which coming to my mind is CMV virus infection. Next, we have a lot of other possible conditions. What we learn, we need to be extremely careful to find an auditory nerve. because there is a high prevalence of not developed nerves, so electrodes need receiver, and we need to stimulate auditory nerve.
Okay, so there's a big difference between children and adults concerning etiology and concerning the diagnosis of single-sided deafness, right?
And of course, it is a little bit beyond etiology, but we, at the moment of implantation, we need definitely to look if it is acquired single-side deafness or congenital. And this is what we can apply differently in adult population and children. And this gives us some tips and some actually guidelines who would benefit from this intervention. If we want congenital, we should actually aim for children and probably reduce the age of the implantation.
Okay, age of implantation. That was my second question. And this is going for you, Kristen. I've seen in the literature you never should implant the children below 5, and I've seen in the literature you never should implant the children after 5. So what happens with the age in single-sided deafness in children?
I think regarding this, it's really important to look at first like the etiology and all this, if it's acquired or if it's congenital. Because if you look at the studies, a lot of groups have like brought big groups together from 2-year-old congenital ones to 18-year-olds or 17-year-old acquired with a temporal bone fracture. So that's everything somehow SSD in children. And I believe when we think about the congenital ones, like you already said, I think as early as possible gives the best results, and we try in Würzburg to 2 years, at least 3 years as oldest age for the congenital ones.
No older than 3 years.
We believe that afterwards, for them it's really difficult to cope with the implant and to be rehabilitated. You need really this plasticity of this young brain to implant. And on the other side, if you have like the acquired ones, there I believe it's like the shortness of deafness is really important. Yeah, so if you have an acquired deafness in a 6 or 7-year-old child, then it's really important to implant them quite fast.
Okay, that's very easy. Doctor, I have a kid. My kid is deaf on one side. How would you tell me if it's congenital or acquired? We never realize anything.
Like you have the newborn hearing screening?
Hearing screening was not definite. I mean, it was passed, but we don't have the results. I'm coming from a different country.
Yeah, then it's difficult.
Okay.
Discussion.
I knew. And how we solve that, Artur?
No, I think that this is a really critical decision, and honestly, in the clinic, we struggling to definitely say that it's congenital of early acquired, and we try, of course, to do the parental interview and try to find that onset of hearing loss, but. Because of this reason also, our population of children of SSD is not so young as we know that it would be actually feasible. That's why we, as I remember, our last study, we have a mean age of 3 years old. But
how much?
3 years.
3.
Acquired, but with some, distribution to the left and the right. So we definitely have children of 5 and 6 years with suspicious congenital and maybe acquired, because some of them they pass. We have information that they pass the screening, but some actually results were not so clear.
Okay. I've seen also in the literature that the children, when they use their single-sided deafness implant, they don't use it as much as a bilateral cochlear implant or a unilateral cochlear implant or an adult. I've also seen in the literature that this may be due to not enough stimulation of the low frequencies.
Okay, seems quite provocative. But I think that the problem with the literature is what was actually said before, that when we are starting with a new group and want to publish the first results, it's really a mixture of children with different ages, and that this is not definitely a homogeneous group. If I want to do this first series to be more homogeneous or to stratify, I end up with small numbers and the statistics are not working, and etc. So I think that the most problem with usage, and I'm going actually to present on this topic in 1 hour, is that you really should try to define the age of implantation, if it is actually acquired or no. In my cohort, the small children, actually, they use that with no additional actually issue and problems. And the mean usage time is 8 hours. And if they are small and you calculate that they need to sleep and etc., it means that actually 8 hours is close to 100% of their waking life. And this is quite interesting, because this actually probably very depends on counseling and motivation of parents.
Okay, Professor Hagr. Now.
Okay, I had an interesting case in my panel today on difficult cases from Romania, and this was a girl who developed the deafness in the course of the first 8 years. She started hearing, and there was a nice audiological follow-up. With 3 years, she started with hearing aids, and at the age of 8, she was deaf in this ear, and then was implanted. So is it in contradiction to your proposal, Kristen Rak, no longer than 3 years, if the child has heard? That's the first question. And the other question is to the audiologist. Now we are more and more in favor for genetic testing, genetic screening, also after birth, and maybe we filter out all these children with a normal hearing screening, but with a genetic defect which will lead to a later onset of deafness.
Okay, quick answer, because we are short of time.
But this girl, in my opinion, is an acquired single-sided deafness, so there's different. It's not a congenital one with totally deaf born. And maybe I also comment on the second opinion. I think we've heard this data from Ontario, where they're doing with all children in Ontario already a genetic testing for hearing loss in the beginning. I think that's the way we should go. So we really find the children who have the danger of getting or developing a deafness or hearing loss quite early, and can diagnose them and treat them quite early.
But I think that I have a long discussion with our genetic group, and they try to convince me that single-side deafness is very rare a genetic issue. It's completely different than the bilateral. So that should be also taken into consideration.
Heinrich, is you?
Yep.
Yeah, go ahead.
Hi.
I see nothing. We are deaf and I'm blind.
Kristen, your statement about early implantation of congenital kids implies that there's a critical period for the maturation of binaural function effects. So if you then have a child who has an absent nerve or a completely absent cochlea, would you fast-track the ABI process as well?
That's hard for me to answer, because we do not have SSD children with ABI. I think it's in these cases we try to go quite early for bone conduction devices, to help these children in the beginning with the soft band, and then as early as possible with an implantable bone conduction device. I'm not sure if there are many children, SSD children with an ABI on one side and normal hearing on the other side. Probably there are, but I do not have any information regarding this.
Last question.
I think that in unilateral deafness, it's very important to screen for congenital CMV, even at the newborn period, because we can act if there is enough evidence that is congenital. And even it can help us to decide to implant that child before the other ear can suffer.
Yeah, that's absolutely true. But another small consideration: we are talking congenital hearing loss, but of course we can have not complete the deafness at the beginning. We can have a progression after CMV. So again, it changed this, let's say, clinical decision-making process, because if a patient or child can hear at the beginning, even with some hearing loss, and next, like this example was that at the beginning was hearing aids, and it was a progression, it completely changed the picture, because the plasticity of the brain works in a different way. So at the beginning, probably it was developed, the binaural process is developed because of a binaural input.
Okay, last question. You have a child, your son or your daughter, single-sided deafness within the age you've mentioned before. Yes or no? Cochlear implant. Artur?
Yes.
Kristen?
Yes.
Okay, next couple. So, let's move to the second topic. Second topic will be hearing preservation with long electrodes. And we have for that Professor Meg Dillon. Meg Dillon is here. She's the Director of Cochlear Implant Clinical Research at the University of North Carolina, Chapel Hill. Their team is focused on outcomes of pediatric and adult patients with hearing loss. And Hearing is delighted to have Meg today among our active members in the hearing group. And the second is the surgeon, Dr. Nick Thompson from Chapel Hill also. He's assistant professor at the Division of Neurotology and Skull-Based Surgery of the UNC School of Medicine, and he specializes in the medical and surgical treatment of both adults and children with ear and lateral skull-based disorders. Today, we are happy to have you among our panelists. And the topic, as I said, is hearing preservation and long electrode arrays. Come on, are you going to tell them that you can preserve hearing with a long electrode?
Do I say heck yeah? Or I don't know how casual we're being with this. Yes, that's the punchline. Sorry, spoiler alert. Yes.
So yeah, there have been a couple papers out from various groups, not just us, and about 70 or 80% of the time with a FlexSoft electrode, you can preserve hearing of some sort. I know there's a lot of different definitions, and about 20% of the time it's at total preservation within 20 dB of where you started with.
Okay, so we can preserve hearing with long electrodes. Now, the surgeon's view is, I did a great surgery, but what's the percentage of hearing preservation after that wonderful surgery in reality?
Well, that's your data. You want to talk about that a little bit? Yeah.
Yeah, so this is, you can see this kind of bottom, low, mid to the left. These are the low frequency pure tone averages. This is the pediatric population. We have, which I'll actually be presenting on this, again in the next hour as well. We have this similar data for adults, but you can see there's a, little bit of drop with pre-op to, you can see this little bit of drop with pre-op to activation, and then we follow these kids out, and you can see the low frequency pure tone average is fairly stable out to 1, 2, and 3 years. So even in the pediatric population, it's possible to preserve hearing and keep it around. And again, some of that ties into different etiologies of kids as well with progressive hearing loss. But overall, yeah, you can maintain it.
Meg, do you want to have contacts, electrode contacts, in the upper part of the cochlea in these patients, or you don't want to have them? Because you have patients still hearing that there, and you have an electrical input and an acoustic input. Do you want to have that?
I want to know about it. I think
Okay.
is the way I would answer that. So I think when we know about it, then we can do something about it. And actually, it was really interesting to do this work because it opened up, as most research does, multiple other questions, but it also helped us figure out why some patients were performing poorly with EAS. And so one important point here is this: we're talking about functional acoustic hearing, not 90 dB. This is functional acoustic hearing that we're wanting to aid. And so now when we recognize that there are electrode contacts within that functional acoustic hearing region, we are turning them down. And so that's what you're seeing with the image of the map. So with these patients, we are doing place-based mapping. So we are aligning the filter frequencies, the electric filter frequencies, to match cochlear place. And so in the case of an electrode contact that is within that functional acoustic hearing region, we're turning that stimulation down so that we can hopefully limit electric on acoustic interference. What I really like about this technique, and I'm glad to be able to work with this patient population, is if they lose hearing over time, we can just simply turn that electrode back up and it's back in play. We're not changing filter frequencies. They're not having to acclimate to something new. They have that familiar piece, and now we're just representing one frequency region electrically when we can't acoustically.
Okay.
It's a safety net, I would
So,
say.
okay, that's a good approach. I mean, you disconnect it, but you can connect it. But the fact of having that electrode there does have an impact on the long-term evolution of this hearing loss, of this preserved hearing?
So long-term hearing preservation, so again, this is a little spoiler for my talk in an hour, but in the adult population, the just overall incidence of contacts in the functional acoustic hearing region is about 60%. And you can see this down here, where this is split between Flex 24, Flex 28, and Flex Soft electrode arrays. And we see this phenomenon, throughout all three arrays. In the pediatric population, it's actually a lot higher, in the 90% range, actually. So, of these down here that we saw that this hearing preservation was maintained, vast majority of those had electrode contacts in the functional acoustic hearing region. And again, we see the same thing for adults. So it doesn't necessarily predispose to a delayed loss of residual hearing, whether that be a physical phenomena or electrical stimulation.
Okay, Meg, can you give them some technical considerations regarding the fitting of a patient with hearing preservation with a long electrode, apart from disconnecting the ones on top of the cochlea?
So with EAS patients, so when we have functional acoustic hearing, and when we're looking at the audiogram that you can see over me right now, we're with the default mapping, so the way that we program now, we base everything off the audiogram. And so we're looking to see what is that functional acoustic hearing region that's indicated in blue. Yep. And then what is exceeding that range, that's indicated in green. And those are the frequencies that we're wanting to represent electrically. And so some of the foundational work that was done with the EAS programming was you really want to make sure that there is no gap in the frequency information that you're presenting. So we amplify the acoustic component in that range that we can. That's where we start the electric stimulation, and all of that's being represented by the cochlear implant. And patients did well with that. We have a lot of patients that thrive with that, but what we're now learning is when you incorporate the audiogram plus the placement of the electrode array, the patients can do a lot better when you have these discrepancies in where that electrode is. Either is it very basal compared to the functional acoustic hearing region, like the cochlea that you're seeing on the left, where we can see the blue region is our functional acoustic hearing region. We can see that we have a gap in where our electrode contact is stimulating versus that functional acoustic hearing region. Or are you a patient that has multiple contacts within that functional acoustic hearing region? And once we can control for those two conditions and account for that in our programming, I think we're narrowing the variability and performance that we're seeing for our EAS users and seeing a higher rate of EAS use.
Okay, let me see if I got it. Anatomy-based fitting is good for these patients.
Yes.
Okay, good.
Yes.
Now, yeah, okay. Now, give them some tips for getting surgically a good hearing preservation. What do you do? Yes, short answer. Yes.
Well, seems
basic
silly.
Steps.
It seems silly coming from a young neurotologist, but
you're young.
But I think this will continue to evolve and become more and more common with heard earlier about a lot of robotic techniques, drug-eluting electrodes, and things like that. So I think this phenomenon will be more and more common, which I think is good because it kind of mitigates a little bit of the risk. Like you mentioned, if you put a shorter electrode array and then you lose hearing, well then you're not stimulating anything deeper in. So those patients do the worst. But if you're able to get long electrodes in consistently, with some of these other techniques that are coming out, and device designs, things like that, I think it'll be good.
Well, I have a question for you also. I always say that right now, every single cochlear implant should be done using hearing preservation technique. Because the only way to get hearing preservation the day you need it is to be used to that. I mean, you are not going to get that the first day if you are not used to do that. Do you agree with that? I mean, you do every single case with the same steps as for the other when you have to really preserve hearing?
Yeah, I agree. Hearing preservation cases, it really makes you focus on getting full exposure to the round window. But, I was trained to, like you said, do that every case and do everything, as if they had hearing. If they're profound, sometimes it's letting the trainees put in the, electrode. Obviously, with hearing preservation, that's on me. But otherwise, the approach and everything like that do the exact same.
Okay, how do you enroll the patients? I mean, how can you get a patient with a still hearing ear get involved into a cochlear implant, making go with your colleague to the OR?
So I think we're in a unique position where by the time they get to the cochlear implant clinic, they're thinking about it. If we take, or considering a cochlear implant and really weighing, is this the right thing for me? So they're already going down that path. I think to answer your question, if we take it one step back and think about our audiologists that specialize in the fitting of hearing aids, that's when those discussions are really critical of how well are you doing with this hearing aid, and should you consider that cochlear implant evaluation? And that's been something that's been really great for our team, is our hearing aid audiologists, our cochlear implant audiologists are all in the same place. And so those conversations are happening, and something that my colleague Lisa Park and I talk a lot about is the benefit of having both groups in the same clinic, because then a patient is sitting in the waiting room and they can see you and your wife having a discussion, and that's easy for them. But I'm still struggling. What's unique about you that maybe I should be considering? So I think that helps us move things along the process better than we would if we were in a siloed situation.
So the message is team work.
Well, teamwork, but also team discussion. So we also have monthly meetings where we're talking about new evidence that we're seeing in our clinical research, and that makes it more easily applied into our clinic. And I think that keeps the conversation going between all providers.
Okay, I think this is precision medicine, and precision medicine requires a multi-institutional, multi-specialty approach, a multidisciplinary approach. Otherwise, you are not going to be able to do it to get good results. Do these patients need more time or less time to reach peak performance? Is this a faster or slower procedure compared to a conventional cochlear implant?
So are we thinking about, we've applied these individualized mapping techniques. I would say that's still under investigation, but the preliminary data that we are seeing is yes, that we see that they are doing better, faster. We've also looked at our clinical trial folks in addition to our patient population, and looking to see which patients are not following up, because we've all heard about patients who are not returning to the clinic, they're not wearing their devices. Within our research, the patients that have withdrawn from the study, those are patients that have significantly more mismatch than those that remain in the study. And I think that's compelling, because we're not seeing sociodemographic variables contributing to the lack of non-use or the lack of returning for follow-up, both in our clinical trial population and in our patient population. So I think this is a variable that, as audiologists, we should really be paying attention to, because if you're not doing well early, then you might not come back, or you might discontinue use when you really could be benefiting a lot more.
Okay, almost last question. Yes, Rudolf, Professor Hagen, may we have a microphone there?
We learned that it is absolutely necessary to stimulate the apex of the cochlea, either acoustically or electrically. Isn't there a dilemma if you have to decide inserting a short electrode, and later on the apex cannot be stimulated. And if you are on the safe side, having a standard electrode up to the apex, and if the hearing is gone, then you have the perfect electrical stimulation. For me, this would be some sort of dilemma in counseling the patient.
Yeah, that's a dilemma for sure. Like I mentioned, I think hopefully the risks of that will be less and less as the drug-eluting electrodes become more common. You know, robotic insertions, we can consistently get deeper, get a full complete cochlear coverage every time, but then be able to turn those electrodes down so we don't have electric on acoustic interference.
Well, last question is concerning reimplantations. I mean, a child that has been implanted yesterday will need 2 or 3 implants in their lifetime, right? So from the reimplantation standpoint, just looking to the future, would a short electrode or a pre-shaped electrode be less traumatic to remove and reinsert, or we have no choice at all to do any removal and reinsertion and still keep that hearing? What's your opinion? Because it's just theory right now. We don't have experience on that.
Yeah, I think my kind of guess of things essentially with reimplantation, you have kind of a fibrotic sheath that forms. Lateral wall arrays are nice because it'll just thread right in there. Whereas with some of the pre-curved, you have to make sure that it follows a trajectory, doesn't have fold over, all that kind of stuff. So.
Okay, last question, then this is the real last question. Do you have a situation compatible with an EAS? Meg, would you get a cochlear implant?
Would I get a cochlear?
Yeah.
Yes.
Yes.
Yeah.
Yes.
Nick, okay,
Yes.
Thank you very much. 2 yes. So, thank you very much. And let's move to our last dancing couple tonight. We will have here Yassin Abdelsamad and Professor Abdulrahman Hagr. Please take a seat. Yassin is researcher in the field of hearing implants. He holds an MSc and a PhD degree in biomedical engineering from Cairo University, and currently he's a PhD candidate at the University of Antwerp in Belgium. The hearing is very glad to have you, Yassin, among our panelists in this roundtable. And Professor Hagr doesn't need an introduction. He's everything. He's the big boss in the Middle East. He's the president of the Saudi Oral Society, as well as of the Arab Academy of Otology and Cochlear Implants. He's professor at King Saud University and the director of King Abdullah Ear Specialist Center. He's one of our most active members. And we are going to deal with them with something which is early activation. And I've heard we've had before this session, we have a session on early activation. But my first question is to you, Rahman, because I mean, you're the father of this idea. You're the one on top proposing this approach. How early is early? Are we going to do pre-implanting activations? Are we going to go with the patient with the implant already activated, or this is too much?
Well, thanks a lot for this questions, and I'll give you 2 options, okay? Either I answer you now with accurate answer, or I answer a month after with the same question, with the same answer, but may not be more accurate, okay? So it's the same thing with the early activation. We are waiting for a month to get the same result, so why not to take it immediately, okay? So the early activations, we find it, we've been doing it for the last 15 years, okay? And we are extremely, extremely happy with the success we're having with the patients, with ourselves, with the audiologists, with the patients. And tell you the truth, we end up getting more and more patients because a lot of patients are interested in the early activation and seeing the immediate effect of the implants. Answering your question, we started at the beginning with a pilot study, 5 days activation, and it works nicely. Then we moved to next day activations. Then we moved to same day activations, okay? But guess what? This is what opened our mind with the anatomy-based fitting. So with the anatomy-based fitting, we look to the anatomy of the cochlea pre-operatively, and we can tell exactly what the programming is supposed to be post-operatively. So no doubt one day we'll be activating the implant pre-operatively.
So a short answer. what will be an early activation? I mean, we have, a standard is 1 month. 27 days is an early activation, 20, 15, 10, just for them to manage their changing from the traditional to the new one.
Okay, so we think the earlier the better. The earlier you can do the activation,
That's a
the better.
political answer. I want a surgical answer.
Within minutes. My answer is the earlier, like immediately intraoperatively, you activate your implants.
If I do it 3 days after the operation?
I'm really questioning if you would end up with the same benefit of early activation. But because, you know what, we look to a lot of study which shows that inflammation and fibrosis start early stage, okay? So, and this happened even for people who got like a histology, like, 30 years after. It shows the same fibrosis and inflammation happen. So it happened in the early stages after cochlear implant. The time you have the trauma, the time you have a foreign body. So the electricity, we think it's the things which will work more than steroid in suppressing the inflammation and give you more hearing preservations and give you a better outcome. And we are studying it and we are trying to see how early would make a difference. Which the time we would say, like for 3 days, it will be the same like a month after. This is one thing we are studying and we are not having the answer yet, but it seems to be the early we go and activate, and this is what we do with the adult intraoperatively. We do adult sometimes bilateral simultaneous. We activate it immediately intraoperatively. So we think those patients will benefit more and get less inflammation.
Yassin, why is this topic so controversial? Why is this such a hot topic? We are doing now early activation. I don't know if after what he said is early activation or late activation, but anyway, I found so many problems of infrastructure that I don't know if this is one of the reasons for the controversies around early activation. What this is such a hot topic?
Yeah, well, thanks a lot, Professor Gavilán, first of all, for your introduction. And I'll just go back to the answer by Professor Hagr, because according to the literature, the early activation is, till now, activating the audio processor from 1 day to 14 days after the CI surgery. But this is a very wide definition, and there is no agreement or there is no consensus on a specific definition for the early activation. But as Professor Hagr mentioned, the earlier the better. So in our center, we consider the early activation as up to the 2nd day. So in all of our studies, all of the included patients are activated up to 2nd day of the surgery, either on the same day or on the 2nd day of the surgery. And what makes this hot topic, because it has some impacts on many aspects. One of them is the electrode impedance, which is gaining more critical roles in the cochlear implant field, and also the psychological impacts, the magnet issues, even the anatomy-based fitting recently. So it goes with the directions of advancing the cochlear implant field. That's why it gained this importance in the last few years.
Rahman, tell us something about tips and tricks for early activation from a surgical standpoint. What shall I do tomorrow to make early activation easier during the operation? What do I do now?
Well, tell you the truth, even ourselves as a surgeon, we modify our technique in a way that we make it as minimal incision, as fast, as easy, as less traumatic in all aspects. We are not just talking about soft surgery for the cochlea, but rather soft surgery for everyone, even for the patient for anesthesia. Anesthesia is a major hazard for our patients, so we would like to minimize the time of the surgery. So all these aspects comes like one package. And by this, we are actually ending up with the almost no dead space under the skin, so easily the magnet would hold. And also the magnet is almost working like the head bandage. So you are saving a lot of things and a lot of costs and a lot of issues with the late activation. One thing I think we should look at it here is that we should apply for the Guinness record in medical field, because there's nothing in medicine which continue for more than 50 years without changes, except the activation of the cochlear implant. So I think this is the time we should change it. Almost we are in the 3rd generation of a cochlear implant surgeon, and we're still practicing what started long time ago.
Professor Hagr, Professor Hagen.
Oh, the difficult question.
Thanks to both. Of course, I admire your consistent way to introduce the early activation over all these years, but you know the reason was when we started 20 years ago, 30 years ago, we had this big trauma, this big opening, and now we have minimal invasive surgery. So now it's the time really to introduce it into the general way how to do implantation and activation. But my question is, do you start the same protocol of rehab only earlier? So you need a rehab program, and it is organized at the next day they start, or is it done remotely in your country with all the long distances?
Well, first of all, thanks a lot. If you are the first one who's converted to the early activation, it's the greatest success I have. And I'm glad you mentioned this important topics. Like I used to be one of those surgeons who end up with a big incision, shaving half of the head and making suture fixations. And that definitely not the way you can go with early activations, okay? But I'm sure all the surgeons here, they changed to the minimalism and a small incision. And there is no point for waiting for this 1 month technique of fitting. So we moved everything toward next day fitting. So the surgery, it's become all of them almost day surgery, okay? The audiologists immediately get involved. The speech therapists immediately get involved, okay? And even with bilateral simultaneous cochlear implant, it's even the same thing, you know? Get fitted, get programs, and full package comes from next day.
Yassin, I cannot use early activation. I will have magnet problems. Those are the comments I got when I started early activation. You cannot use it because it's swelling and magnet will not work.
Yeah, to answer this question, I have like 3 answers, okay? One of them is from the literature. And what we have from the literature, we have one paper from Frankfurt on this aspect, and they reported that they needed to adjust the magnet with the early activated patients in like 30% of their population. And there is another paper from Ankara, from Turkey, and they reported that they managed to adjust the magnet for 8% of the patients. But among all of our populations and all of our papers, which now we have more than 1,000 patients, most of them are activated early. We didn't figure out, and we didn't find this a big issue with our population. So I don't think that the magnet should be considered as one of the consequences of early activation. It could be a consensus or a consequences of the cochlear implant surgery in general.
Come on, how am I going to put a magnet in a child the day after the operation with the skin suture? This is going to open the wound.
Well, we didn't experience this at all, and tell you the truth, we are conducting one of our research projects on the early activation as well, and this is really, this is please a secret, it is just between you and me. And the only thing that we are struggling with those patients is that for some patients, we need them to be activated 1 month after the surgery, and the rest would like to be activated on the second day for the study design. And we are struggling to convince those who should be activated after 1 month, and they come to us and ask why you are activating us that late. So we didn't face such problems with our population. Yeah.
Okay.
One extra answer. So
sure.
We are doing this humanitarian cochlear implants, and we are doing it in those emerging countries, and those children may not have the best, medical situations and malnourished. In spite of this, we thought always about early activation would end up with complication and so on. Until now, we did not face these issues. So I think even for those countries in Africa and those people with the not the optimum medical health, still the early activations and the anatomy-based fittings is the easy and the fast way of doing it.
Professor Hagen, Rudolf.
What about children with additional handicaps and syndromes? The same strategy, or you know, sometimes the results in these children are not as well as in normal, healthy children. So that could create problems, this new concept.
This is another very good question. Tell you the truth, not everybody would go for early activation. Like people who are still dizzy, children who are still dizzy, dilated vestibular aqueduct, still next day, still they are, you know, having nausea and not, you know, staying or in good health for early activation. Some of the patients we are not going with early activation unless they are completely awake and stable. And most of our patients, they are awake and stable and easy going. So there's another thing that our anesthetist is doing is a nerve block. So they are giving less morphine and less medications. So all of this actually comes as a package with the early activations. These are the syndromic and difficult cases. We're still in considerations, like if they are not really completely awake and ready for fittings, we do it like the day after. But I don't think anyone who would take more than 2 days to be ready for early activation.
Okay, you see we're out of time, but I just want last comment from you. You're the father of the idea of early activation. What was your motivation to use this approach?
Well, tell you the truth, I'm not the father. The father.
You're the mother.
No, it was my patient, one of my patients who was blind, and he came a week after, and he insists to have the implant, and he has bilateral fracture of cochlear. So for me, it was the most difficult case ever I've done cochlear implant.
I've seen the video.
The last one, exactly, and was the last one I would consider going with early activation, but he insists, he came like for 5 hours drive, and he insists to have it. So we said, why not? So he is the one who got the credit for early activation.
Okay, last question. Yassin, for your cochlear implant, early activation, conventional activation?
Early activation, definitely.
I will not ask you, Rahman. Okay. You prefer conventional, right?
Conventional early.
Okay, thank you very much. We're out of time. This is the hearing. We are here for you. Anything you want, send us your comments or your questions. We will be glad to answer all your issues, and we would love to see you in further meetings. We are very active right now in almost every single hearing meeting. We are as a group having a roundtable or a symposium like this one, and we really appreciate you being here this afternoon. Thank you very much, and thank you to the panelists.